Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Jay Calvert, once again here with my architecturally interesting podcast co-host, Dr. Millicent Rovelo. How are you doing?
I'm doing well. Although I think that's like a euphemism for you have a funny looking face when I hear that. You know, kind of like she's got a nice personality. She's architecturally interesting.
I went with architecturally interesting because of your architecturally interesting nose.
Oh, okay. Fair enough.
Which becomes more interesting every month that goes by. I think it's kind of going very well over there. What do you think?
I love it. I love my new nose.
I'm glad you love it. And it is the architectural approach to rhinoplasty that I was interested in talking about today. If you're up for it, another rhinoplasty topic.
Always up for rhinoplasty.
Well, good, because there's all this there's been battles over how to do rhinoplasty, closed versus open, preservation, structural, a bunch of stuff that I think I'm now going to join in on.
Okay. So tell me, what is your contribution here?
My contribution, if I were to write a textbook, which I highly doubt that I ever will, the textbook would be called Architectural Rhinoplasty.
Ooh.
That's pretty good. Yes, and that was the reaction that I was hoping for.
Okay, good. So what is architectural rhinoplasty to you? Or really just in general, because you just made it up. So
yeah, it's been...
So not to you, just, yeah.
It's been a while that I've been saying that term, and I've always felt that, should I go to Springer and say, let's write a textbook or a team or whoever, and I've felt that architectural rhinoplasty really represents the concept whereby you are planning the rhinoplasty, much like an architect plans the building of a building, and you need to have certain things in that nose to make it A, look great, and B, be functional. And it's all connected. You can't ignore the form without the function. It has to be, they're intertwined, they are commingled, they work together, it's all part of the same thing. And if you approach it that way, what I found is that no matter what I find in a nose, no matter what problems are there from a previous rhinoplasty, if it's a congenital problem, if there's humps or diving tips or weak cartilage, if you take an architectural approach, you're going to wind up with something that you really like that's going to be consistent with what you want the nose to look like and should be functionally sound.
Which makes sense to me, because when I think of architecture, or when you say the terminology architectural rhinoplasty, I compare it to what has historically been referred to as structural rhinoplasty. And in the plastic surgery world, when we hear structural rhinoplasty, we think of adding structure to the nose, making it stronger, giving it support. Architectural anything is going to do the same thing, because you can't have a building without structure. But when I think of the word architecture, I think of something pretty, something designed, something beautiful, something that has, an aesthetic look to it. So to me, it sounds like you're combining the aesthetics of how something looks with like form and function.
Yeah, it's just that. I think the term structural rhinoplasty is a bit crude for me. That sort of misses the point. Whereas architectural rhinoplasty, people go, oh, I get it, like an architect.
Like an architect.
Yes, so like an architect, the way that I think about rhinoplasty is obviously making a diagnosis first. You look at the nose, you listen to the history of the patient, you go through all the ins and the outs of why the person's there in the first place to have rhinoplasty, and then you begin your planning phase. You start to say, well, what would you like? What is it that you're looking to achieve with this operation? And then you take those goals and start to marry them with what's possible and what you can do for the nose. And of course, in my world, there are things that I'm looking for as I do a rhinoplasty. I'm looking for great tip support. I'm looking for the external and internal valves to be workable, to make sure that they're going to be supported, but also they have to look, the external structure has to look nice, right, despite the fact that we need to use cartilage grafts or the native cartilage to do the job of keeping the nose working. It goes all the way from the bones down to the tip of the nose, to the septum, all the way into the ethmoid plate and the vomer. And in order to really be a nose architect, you have to know where you're trying to get to. And that, of course, comes from plans. So when you have plans and you know what you're looking to do, then the architecture of what the moves are, what graphs you need, what needs to be reduced, what needs to be built up, that becomes very obvious to me. And so you sort of get into this nose whisperer type of situation where it's like, I don't think it matters what you find in the nose, as long as when you finish, you've got all the stuff that you're looking for so that the nose works and looks great.
And you got to have both. You know, a nose that looks great, but you can't breathe through, it's not a happy nose. And that is not a happy patient. They will be back. And same thing, you build a nice nose that they can breathe through, but it doesn't look good. Well, the patient may or may not be happy with that. So you kind of got to have both.
You do. And that's why the principles of rhinoplasty are much more important to me than the sort of the rules and the possible graphs and the naming of this and naming of that. And
The 5 reasons for a Collier-Miller strut.
okay. Are you looking for a rant? Is that what you want?
No,
You're looking for a
I
rant.
needle you and then I cut you off. I'm like, I poke the bear.
5 reasons for a Collier-Miller strut. The 3 top reasons that people want to have rhinoplasty. I mean, oh my God. It's like, it's social media communication it's really gotten sort of over the top too much, hasn't it?
I mean, I was making fun of that because that's classic, like board questions, things we have to know in our exam, and we have to be able to regurgitate it, as part of our learning.
Of course.
So, and there are very real reasons to learn it because these are things you need to know. But in actual practice, once you've been in practice for many years and what you do is sort of innate and you have a real understanding, you're not looking at a nose and thinking like, what are the 5 reasons I would do this? You're looking at it from a really holistic, like, overall, how am I going to make this overall nose better? Important things to know.
Sure.
But not necessarily applicable, at this stage.
Yeah, those 5 reasons for this and the top 6 reasons that this and the 3 ways that that's all, I guess, useful to know the options, and you should know the options. But the communication style has gotten, it's gotten weird. It's really gotten out there. I bet, but you got to compartmentalize. You got to be able to package stuff up for people to learn it. They want that. They want to be able to, have test questions. That's a big thing, right? Board questions and recertification questions. So you want to have all that, but I don't know. I'm gonna reserve my rant for.
Yeah, this one's not worth it.
No, it's not, and nobody cares.
Nobody cares.
But they do care about having a beautiful nose that's functional.
1,000%.
So with that, I do want to say that in terms of the things that you can do, the 7 things that you can do to plan your rhinoplasty, you do want to obviously make the diagnosis of what the problems are that you're addressing. I think that sounds so silly to say that to doctors, but think about it. I mean, you need to know
what's the problem.
What are the problems? Yeah. What's the diagnosis? Why can't they breathe? Just saw a patient that has seen, I think they said 14 surgeons about their airway obstruction. And the patient says, I can't breathe. I'm miserable. It's been bad and it's getting worse. And everybody I go to says my airway's wide open. And I've had a septoplasty, I've had this, I've had that. I've had the rhinoplasty, and I just cannot breathe through my nose. Okay. So I look, and the airways, like, there's a person in front of me that's, let's say, 5'10", but the airway looks like it's somebody that's like for like a kid, like somebody who's like 3'6" and hasn't actually grown up yet. And I was like, yeah, the airways are open. They're this big. They're the size of a drinking straw. And I said, so they're open, but it's not enough. They're too small. And then sure enough, on the imaging, you could see that the bones have been brought in too much. Like all the things, it's all right there. But at first glance, if you don't dive deeper and say, why is this person who's seen, and maybe I needed that fact that they'd seen so many surgeons.
To look a little bit deeper.
To go, well, they're missing something, aren't they? Because she says she can't breathe. And, then I have her breathe in and everything collapses and it's terrible. And it's because everything was very narrow and very constricted. So just taking that minute to look a little bit further, get a little bit beyond the obvious, because the airways were open and the septum was pretty dang straight.
She needed more.
Needed more. Got to look a little further. So in that's where the architectural piece comes into. Make the diagnosis. Know what you're dealing with. What's your platform like? What's the foundation look like? Start from the bottom. Go to the top. Look at every aspect of it, and that's how you really get to the best plan for that individual patient. And of course, when you're there doing the operation, you know what you're trying to do. You know what you're trying to achieve. And if you can have the vision for the final result, that's when you can get the structure and the function all to work together and get a great result.
A la an architectural rhinoplasty. I like it.
So I just wanted to kind of explain that.
I like that. When is the series of books coming out? Volumes 1, 2, and 3?
I'm hoping that sometime long after I'm dead, that some ghostwriter will come around and say, I should really write this stuff up. Yeah. It's very helpful.
Let me talk about the techniques of Calvert.
I just don't think it's happening. I think
it's hard. I got to give props to the people that write textbooks. That is a feat. Oh, it's impressive.
I don't have the time. Yeah. It's like, I think something has to give if you're going to get a textbook done. I knew a guy who wrote a textbook when I was a medical student. He was a plastic surgeon. He got divorced, but his textbook got done. So he gave up his marriage to write the textbook. Something has to give, I know a plastic surgeon wrote a textbook, blew his brains out, after finishing the textbook. Jeez. So yeah, I mean, there's like things are bad when you have to work that hard. So I think everybody who does do the textbook thing, you got to give something up in order to get it done, because it's a huge undertaking. If you're going to write it, if you have everybody else write it, then I don't think it matters. That's the classic
way to write a textbook.
Oh, and I'm not doing that. If I'm going to write the textbook, I'm going to write the textbook. I'm not going to say, I'm writing a textbook. Hey, so and so, give me a chapter on DCFs, on spreader graphs. Hey, get my fellows to write these 4 chapters each. Yeah. They got to be done by the end of the year. I'm not going to do that. I don't think that's useful. And when textbooks are written by the residents and the fellows, I don't think it has the same impact like if I were to write the textbook. I think my textbook is this podcast, quite honestly. I think you and I both are able to lay down our thinking about our operations, about the things that we do, and I think it's very useful for people.
Well, then no textbook, just podcast. I'm okay with that.
Are you good with that one?
Yes.
Cool. Well, anyway, I think that's where we stand today for architectural rhinoplasty, and this is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.